Hello, everyone. Thank you so much for joining us for today's panel discussion. My name is Allison Hamblin. I serve as President and CEO at the Center for Healthcare Strategies, and I am so honored to welcome you to today's panel, Gun Violence Prevention and Medicaid, State of the Field. The impact of gun violence has reached tragic new heights in recent years. In 2022, there were nearly 50,000 lives lost in the US to guns by homicide and suicide, with guns now the leading cause of death for children and teenagers. Gun violence also disproportionately impacts marginalized populations. Latino children and teens were 4 times likelier to die by gun homicide than their white peers, and Black children and teens 20 times likelier. Today, we want to open up the conversation to the role Medicaid can play in addressing gun violence. The toll of gun violence is both human and financial, with a staggering $1 billion spent each year treating gunshot wounds in emergency departments. We don't often talk about gun violence as a Medicaid issue, but more than 60% of this cost is paid for by Medicaid. Instead of paying for these downstream effects, Medicaid has the opportunity to use its resources to invest in interventions that reduce the risk of gun violence. Just as we are seeing growing interest in leveraging Medicaid to address a broad array of social determinants of health, we have the opportunity to consider violence intervention programs in this same light. There are a number of evidence-based ways to address gun violence and resulting trauma, all of which require improved coordination between payers, hospitals, and community partners to realize their full potential. Today, we're thrilled to lift up this potential as well as provide real-world examples and share ways that Medicaid is poised to serve as a key partner in these efforts. Next slide, please. Before we dive into today's agenda and introduce our panelists, I'd like to provide some brief background on the Center for Healthcare Strategies, or CHCS. CHCS is a national nonprofit that works to strengthen healthcare services to ensure better and more equitable outcomes, particularly for people served by Medicaid. At CHCS, we partner with state and federal agencies, health plans, providers, community-based organizations, and consumers to address obstacles that stand in the way of health equity for people facing the greatest disparities. Our work advances more effective models for care delivery, more efficient policy and program design, and ultimately, we aim to provide more equitable care. Next slide, please. So our agenda for today. We are going to start with some big picture information about the problem of gun violence and emerging opportunities around hospital-based violence intervention programs, as well as other clinical and community-based solutions. We'll hear briefly from our presenters about their work and then reserve the bulk of our time today for our panel to explore these issues with particular attention to practical considerations for how these programs are run and what role Medicaid can play. Note that throughout today's presentation, we encourage you to submit questions through the Q&A button at the bottom of your screen. We've incorporated many of the questions that have already been submitted during our registration process into our planned discussion and promise to leave time at the end for additional audience Q&A. Note that in the coming days, we'll also send out a recording of today's conversation, as well as additional resources that may be helpful to you. And finally, at the end, we'll encourage you to fill out an evaluation survey that will pop up at the end of the webinar. Next slide, please. Okay, so we are thrilled to be examining this timely and critical topic today with our distinguished group of panelists who collectively represent deep expertise in gun violence prevention, trauma-informed care, and Medicaid policy. First, it's my pleasure to welcome Estelle Richmond, who will moderate our panel and provide her uniquely varied policy expertise to today's discussion. Estelle currently serves as the Executive Director of the Civic Coalition to Save Lives, a multi-stakeholder collaboration created to reduce gun violence in Philadelphia. Estelle has had a long, accomplished career, including as Chief Operating Officer and Acting Deputy Secretary of Housing and Urban Development under President Obama, as well as 30 years of public service at the local and state levels with the City of Philadelphia and the Pennsylvania Department of Public Welfare, including oversight of Medicaid and behavioral health services. I'll note that we also have been lucky to have Estelle's leadership as CHCS board chair since 2017. John Rich is the director at the Rush CMO Institute for Health Equity at Rush University Medical Center in Chicago. John's work focuses on urban violence, trauma, and health inequalities, particularly as they affect the health of young men of color. John won a MacArthur Fellowship in 2006 for his work designing healthcare approaches that span the public health, education, and justice systems. And he previously held positions at Drexel University in Philadelphia, the Boston Public Health Commission, and Boston Medical Center. And John is also a valued member of CHCS Board of Trustees. Jayati Newbold is Director of Strategic Initiatives at Ready Chicago, a violence prevention program that focuses on young men at high risk for violence and victimization. Jayati has over 15 years of experience both in Chicago and internationally, working on strengthening cross-cultural partnerships, conducting research, designing evaluative protocols, and implementing intervention strategies across diverse groups of stakeholders. She has facilitated trauma-informed and ACEs training and is a certified domestic violence advocate. Kyle Fisher is Policy Director at the Health Alliance for Violence Intervention, referred to as the HAVI, where he leads efforts to advance evidence-informed policy to end gun violence. Kyle is also a practicing emergency physician and fellowship director at the University of Maryland School of Medicine. He has previous policy and clinical experience with the Healing Hurt People program in Philadelphia, as well as with nonprofits and state and federal legislatures in Wisconsin, Maryland, and in the U.S. House of Representatives. And finally, Brad Richards is the Chief Medical Officer for Connecticut's Department of Social Services, which houses the state's Medicaid program. Brad is a primary care provider and assistant professor at the Yale School of Medicine, where he serves as the director of the Primary Care Innovations Curriculum. He also has previous experience with the Haven Free Clinic in New Haven and Yale New Haven Health. Next slide, please. And now it is my absolute pleasure to turn the mic over to Estelle Richmond, who will provide some additional opening remarks and moderate today's discussion. So Adele, welcome. Estelle.
Yes, she said it. Click the right buttons. Thank you, Allison, for that kind introduction. And also thanks to you and your staff for sponsoring this webinar. This discussion is well timed, as many of us at the city, county, and states are struggling with issues around gun violence and how to save lives and create safer environments. It is critical to understand the intersection of Medicaid and gun violence and how we can intervene effectively to make an immediate difference. I'm also very excited to hear from our speakers and how they're advocating for safer communities in their areas. Before we get to the panel, I want to talk briefly about Philadelphia and how we are beginning to bend the curve in addressing gun violence. In 2021 and in 2022, deaths secondary to gun violence in Philadelphia crossed 500. The good news for this year is our deaths due to gun violence are down about 20%. The fact that gun deaths are down is good. The bad news, so to speak, is we really don't know why, except we believe that several of the programs that have been incubating over the last couple of years are beginning to take impact. In 2021, at the height, though, of our gun violence challenge, a coalition of corporate leaders, foundations, and nonprofits came together to work with the city to find ways as a community to address the violence in the city. There was a recognition that this is a problem that had to be addressed and recognized by all players, just not by the city. Government cannot solve this crisis alone. It really takes full collaboration and work by everyone who either works or lives in the city. And that meant large and small corporations. It meant large and small foundations. It meant large and small nonprofits, faith communities, all to work with the police, the health departments, child welfare, and other city departments to begin to bend this curve. But the constant reminder was this had to be a coalition of all players if we were really going to change the path of gun violence in our city. Hence, probably about a year ago, the Civic Coalition to Save Lives was created and joined with the city to bend the curve on gun violence. I was hired to run the coalition and to create a gun violence intervention coordinating center, which could serve as an integrating force. We're now about a year into a very highly focused agenda to save lives, and the strategies are beginning to work. I won't go into all of those details now, but I will answer questions later. Next slide. As we began originally to look at Philadelphia, it was very siloed. We had a lot of programs, we had a lot of things that had within their right that could be termed effective, but things were not working together in such a way that we actually had an integrated system. So part of the work of the coalition and the newly created Gun Violence Intervention Coordination Center was to tear down silos and to begin to look at what an integrated system begins to look like. I want to share a couple of the lessons that we learned, some of which will be actually better addressed by some of my panel colleagues. The first lesson learned, though, was how to gather your data, understand your data, know who are the people most likely to do the shooting and most likely to die. Second was learning where did we plan to intervene? Was it at the prevention level, understanding that prevention usually takes 3 to 5 years before you get impact? Was it going to be at the intervention level, where hopefully it takes 12 to 13 months before you get some system change? Or were we really going to be looking at systems change, which meant addressing poverty and the element of racism in our society, which usually takes somewhere around 10 years? In Philadelphia, we decided we wanted to focus at this point in time on intervention. And we began the process of identifying young men, primarily young men of color, who are between the ages of 18 and 30, who were most likely to shoot and most likely to die. While we firmly believe that prevention and long-term strategies are necessary, in fact, needed absolutely to maintain some attention, right now we felt that we needed to stop the people dying and we needed to focus on those who were doing the shooting. We then began to identify the key players for the intervention strategy and their roles. The first were the police. This is about gun violence. And working with the police was an important factor, and understanding what they do, how they do it, and where they do it was a key part of our planning. Given that our goal is to keep people alive and out of jail and out of prisons, the police had to be a critical part of the team. The second part, and probably where my interests greatly lie, were the hospitals. Philadelphia is lucky enough to have all of our hospitals participate in a gun violence intervention program or a trauma intervention program. They really are our first line of defense. We have 4 hospital intervention programs and 2 trauma programs. And all of these are descendants of our very first program, Healing Hurt People, which I'm sure John Rich, the creator, will mention. Secondly, we had to make sure that our community programs and supports were actually doing what we wanted them to do and had enough funding to make it work. I want a quick call out to the Chicago Ready program that Jill headed, since one of our replications is of that program, which has been peer reviewed several times with very outstanding results. We also have a gun violence intervention, a group violence intervention program, because one of the things we learned from our data is how many of our deaths are actually are group related and gang related, and how do we interact with both the intelligence and the tracking of retaliation. We also had a high use, but not high enough use, of credible messengers, and began to learn the distance between a credible messenger and a snitch was very narrow, and therefore we had to be very aware of how we supported our credible messengers and what was the backup plan. And finally, we had to get our arms around in a different way what I began to call non-traditional community providers. These are clearly at the community level, at the ground level. These are folks for whom frequently the people who are doing the shooting and the dying are their next door neighbors. These are people who live tight enough in that community where they actually can identify, but they also offer support services and interventions. And our goal was to use them as primary interveners rather than our traditional systems. and it has worked well. Finally, the last part of our strategy, as I heard from primarily the HVIPs and the community programs, was the lack of housing. If you've looked for housing, you know that pretty far down the housing list are people with active criminal records. And the people that we wanted to house had active criminal records. So it made them unattractive partners for housing. We were fortunate and able to convince the Philadelphia Housing Authority that this was our role, and this was where we needed them to step up, and indeed they did. Next slide, please. Our system now is moving towards this direction where the artificial silos are coming down. People are beginning to work together. We are putting money and plans of interaction together so people feel a part of the whole. I describe this slide now as being very fragile, that I think much of what we want to do is there, but I'm not sure that it can hang together without a lot of support. So part of the goal right now is not only beginning to interact with these very high-risk individuals, but beginning to give them support. Finally, the role of Medicaid. As a former Secretary of Human Services, used to be Department of Public Welfare in Pennsylvania, I know Medicaid costs for gun violence. Depending on how broad the definition, the cost of gun violence in this country can range from hundreds of millions of dollars to billions of dollars. Gunshot violence victims are in hospitals. This is where they all are, and this is where our first line of interaction needs to be. Incidentally, the difference between a homicide victim and a shooting victim, we've learned two things. One is accuracy, and the other is the proximity to a trauma center. So the ability to have our trauma centers and our hospital violence intervention programs have a total overlap has made it possible to save lives. But the HVIPs not only offer life-saving medical services, but they provide the community connection. Many gunshot victims return to hospitals 2, 3, and 4 times after the first visit. We also learned that often at that 4th, 5th, or 6th time, they leave the hospital in a wheelchair or so disabled that they take an extraordinarily amount of support medically. We need to intervene after that first visit. We need to provide intensive community support as early as we can and reduce the probability of subsequent injuries. The targeted use of Medicaid funds can really make a life and death difference in this case. Thus, today we will explore the intersection of gun violence, Medicaid, and intervention with the hope of leaving this webinar of understanding how we can be a more effective, more integrated, and a more focused system. With that, I'd like to introduce my colleague, although we let him visit Chicago, but we still want him ultimately to come home, John Rich.
Thank you so much, Estelle, for that important introduction. I'll never forget the day, somewhere in the early 90s, where I ran into my colleague, Dr. Jonathan Woodson, in the stairwell at Boston City Hospital. And that morning, he was agitated. As a trauma surgeon and as a primary care doctor, he said to me, "We have to do something. This violence is out of control." A couple of months ago, a young guy comes in with a bullet hole in his chest. We get him to the operating room in time. If that bullet had been 2 inches to the right, it would have gone straight through his heart. There are some tense moments, but we're able to do the repair. We saved his life. Then this morning, I'm driving to work and I hear his name on the radio. The same guy that we saved has been shot again, only this time he's dead. We have to do something. That was the way that many of us as providers along our careers at various different moments have experienced the problem of violence. That is, in the midst of the crack epidemic in the early 90s, we saw high rates of violence, and we know from the statistics that it is disproportionately impacting particular communities. We know that the homicide rate for young Black men is 17 times higher than that for young white men. And the CDC estimates that for every homicide, there are more than 57 non-fatal violent incidents. And recurrent violence is a driver of the work that we do, because we know that up to 45% of people who have had a penetrating injury, that is a gunshot wound or a stab wound, will have another such injury within 5 years. And 20% of those individuals will be dead. And so the idea for hospital-based violence intervention programs, or HVIPs, the ideas come from both clinicians and communities who have seen this recurrence and have seen these inequalities. As an early career physician in Boston, I did qualitative research to uncover the cycle of violence and try and understand the role of trauma by examining the stories of young people whose lives had been affected by violence and trauma. The goal at that time was really to seek explanations, not, as some would have characterized it, excuses for the cascade of events that often follow violence. We know, for example, that there are multiple drivers to the complex phenomenon of injury and re-injury. They include traumatic stress disorder, a life experience that tells you that the police will not protect you and therefore you have to protect yourself. And many of these reactions to injury are based in basic fundamental needs or desires for safety and survival. And so the idea of Healing Hurt People, which is a hospital-based violence intervention program as it began, was to understand that moment of injury as a precious moment for intervention to interrupt the cycle of violence, both in the emergency department and in the community. And it's about meeting basic human needs for a population that is largely missing from primary and preventive health care. The goals of Healing Hurt People and other HVIPs to meet basic needs, as Estelle mentioned, navigating the medical recovery and the potential disability, ensuring safety, navigating systems like the courts, police, victim compensation, and insurance that are acutely present at the time of injury. Key resources here include community health workers with the lived experience of trauma, as well as social workers who are focusing on health-related social needs. The next goal is to decrease psychological and physical distress. These, we know, drive the cycle of violence. So trauma-informed approaches to directly address the consequences of PTSD in the context of the patient's life, and that's a critical distinction. This includes addressing thoughts about retaliation or about acquiring weapons. And again, the key resources here are social workers and psychologists. And then finally, creating a bridge and a connection to systems of care. So primary care, behavioral health, education, jobs, and housing. And the key resource here is partnerships with community partners. And so in Philadelphia, we had the unique opportunity through a partnership with Community Behavioral Health, the managed care organization for behavioral health Medicaid. Kudos to Estelle, because her innovation along the way, in many places, but specifically here, created this window. And so we were initially funded by grant funding, but always with the desire to transition to reimbursement under behavioral health Medicaid, to create a model of investment and sustainability. And so as we have moved forward, at the end of the day, this is about the care that patients need and deserve as a health equity issue. Medicaid partnerships allow us to shift from what has largely been seen as a criminal justice issue to one that is clearly acknowledged to be a behavioral health, a physical health, and a public health issue. In Philadelphia, this partnership allowed us to, one, have sustainability, to make sure that these services were available for everyone, to create opportunities for innovation, particularly in the setting of COVID, so that we could switch up as needed to be able to provide virtual intervention as well as in the community where it was appropriate. And then greater accountability for ensuring quality, not only from the health system perspective, but from the patient perspective. And so with that as background, I'm very proud to be with my colleagues for this exploration of how we can ensure this partnership succeeds and continues. With that, I'm going to hand it over to my friend and colleague, Kyle Fisher, to take us to the next steps.
Good afternoon. Thank you so much, John. I appreciate it. I wanted to pivot a little bit talking about this Medicaid side of things that John just started telling us about. Next slide. You may be thinking, well, gun violence has been around in America for a very, very long time. And the Medicaid program has existed since 1965. So why are we talking about it now? What is it about 2023 that this is finally coming to the forefront? And it turns out that this is a pretty new idea based on the structures that have happened over the last few years. And I think I saw the list of the participants, and we have a very, very smart, well-educated Medicaid listeners here. But I think it's helpful just to walk people through the why now to help explore what this means and how we can all work together to continue to advocate for survivors of violence. So where this all really did start was in 2010, 2011 with the passage of the Affordable Care Act. Prior to that, most survivors of gun violence were disproportionately uninsured. And as Estelle mentioned in her remarks, following the passage of the Affordable Care Act, that really opened up the window towards improving the care of the violently injured patient. And now when we look at data nationwide, roughly 70% of those impacted by gun violence are Medicaid patients. So that's really where our patients are living in terms of their insurance coverage. And so that clock started around 2014 to be able to build this out. And it wasn't until President Biden was elected in 2020 that his administration included as part of their plan for gun violence that the Medicaid program can and should reimburse for violence intervention programs. They followed that up with an all-state webinar in April of 2021. And that really started the clock for states to start thinking about how they might do this. Now, we got to give credit to John and the folks at Healing Hurt People Philadelphia for really starting that conversation before that by leading the way locally, as he mentioned, in Philadelphia, and experimenting with it as part of a waiver. And that was part of the proof of concept that got CMS and the administration to put this out there. Next slide. And so just over the last couple of years, as of today, we're up to 6 states that have proactively decided that they are going to use Medicaid to fund community violence intervention programs. So you have Connecticut, and Dr. Richards is going to tell us about that momentarily, Maryland, Illinois, Colorado, California, and Oregon. You see a star over New York because as we are speaking right now, a bill was passed in the legislature that is sitting on Governor Hochul's desk as we speak, and she has until Monday to decide what to do with it. And then I put a few dots on the map for other states where we know that something's in the works. Either there's legislation that exists or there is administrative action with the State Department of Health. The dot doesn't mean anything's guaranteed, but just something's happening. So that's where things sit as of today. Next slide. But that's very, very high level. And as everyone on this webinar knows, it's much more complicated than that. And now you may look at this slide and think, well, that's very simple. I already know this. We do Medicaid policy all the time. But I think it's really illustrative of how it's easy to look at a map and say, oh, there are 6 states, it's done. But in reality, it's much more challenging. And just walking through the medical billing process, because that's what using Medicaid for violence prevention is, it becomes really apparent very quickly that there's a lot of work to be done to sort this out. And we really are building the plane as we fly. So, very briefly, if you think about it, for reimbursement of any medical service, there are three big components, right? First, there's a healthcare provider, and they provide a medical service of some sort, and then it flows through the payer before money gets in the pocket of the healthcare provider that did that. And so if you look at all three parts of this, this is largely new territory for the violence prevention field. For the healthcare provider, John mentioned that folks can be recognized as community health workers. But we at the Javi, we actually started a project roughly 10 years ago to create a new type of healthcare provider type, and lobbied the National Uniform Claims Committee to create a new type of healthcare provider called a violence prevention professional. So thankfully, that's one area that there's a good area of development for that on-the-ground organizations can use now. In terms of services and CPT codes, these first 6 states have started building this out and developing it to figure out what this looks like. And I know Dr. Richards is going to talk about that because we met for months figuring out this work of these frontline violence prevention professionals. It encompasses all of these things from peer mentorship and case management and conflict mediation. How do you turn that into a CPT code? So we have some early evidence from these first 6 states on where that is, but there clearly is still more work to be done and room for improvement and places for innovation. And then lastly, the payers. You know, it's one thing to say a state is going to do this, but most of you know, most states are managed care states. And so now we have to do that hard work of taking things and negotiating between programs and managed care organizations and educating both sides about, you know, for the programs, what it means to bill Medicaid, and for the managed care organizations, what these programs are, because this is brand new territory for all of them. So I leave it at that just to whet people's appetites before we get into the panel discussion. And I'm really excited to pass it on to our next presenter from Ready Chicago, a program that we really look up to. They're doing wonderful work. Thank you.
Thanks, Kyle. And thank you for the opportunity to be here to share a little bit about Ready Chicago. I will jump right in. Next slide, please. So Ready Chicago was launched in 2017 and is one of the 3 largest community violence intervention programs across the city of Chicago. It is an innovative, evidence-based community violence intervention model that seeks to identify at the core of the work high-risk individuals and connect these individuals to trauma-informed, restorative, and culturally competent cognitive behavioral interventions. This curriculum is aimed to help people identify skills and to create space for individuals to develop and become more job ready. We do this through our 4 key pillars: outreach, cognitive behavioral interventions, transitional jobs, subsidized and unsubsidized, and support services. Next slide, please. The program encapsulates finding individuals that are at high risk. Now, I want to take a second and talk about what high risk means. High risk are individuals that have past victimization or violence in their background and are known to our street outreach workers who are at community level, who are in these communities, live and work here, who know who's involved in a street organization, who comes from individuals of need, who come from families of need, right? And what we do is we connect them to outreach. That's your gateway in. We want you to know that we have individuals that have lived experiences, that have similar shared experiences, and can walk the path with you. This is going to be that connect as you go through the Ready program model. From there, we put you into our cognitive behavioral curriculum. Now, I want to take a second and say we're doing an intervention program. We are not therapists. So we're facilitated by individuals that are crew chiefs, that are coaches, that all have a little bit of mental health in their background, but they aren't all licensed clinicians. We do have a behavioral health team on the side that does that clinical work for them, but that's a separate and apart concept to Ready. We do these curriculums both classroom and practice, and so we offer up to 200 hours of cognitive behavioral interventions, which our participants have renamed CAD, which stands for Control, Alt, and Delete. Controlling the thoughts, altering negative behaviors and deleting the negative. And through this curriculum, we offer topics like, what does it mean to identify trauma triggers? What are some coping skills? How do we know when we're being triggered? And what is our initial gut reaction? The goal at the end are twofold. One is to create enough gap for you to think through the consequences of the action that you're about to do, and for you to maybe reevaluate those consequences, right? And so once you go through it, take that 8-second pause and hear more about what this can actually be, chances are you're going to change the way you're going to respond to that trigger. That's our goal. And the second goal is to create and ultimately inform that baseline, right? What are we all doing here? We're all working so that we can fund for our families, so we can afford for our families. So to ensure that through both the curriculum and the transitional jobs, you are getting paid. There are stipends, there are incentives, there are wages that are associated through the program, so we can actually help cover and bridge the gap of lost income because they're a part of the program. Through the transitional jobs, we offer wages. Each participant has incentives that they can work up to. So we start at minimum wage, which is $15.80 in the city of Chicago, and then we go up to, depending on how the participant is doing, and ultimately connect them through a pathway assessment to career opportunities in diverse sectors, healthcare being a few of them, construction and manufacturing being others, digital literacy being a third, just to name a few. And then lastly, we do all this through the support services tool. So we understand that individuals that live in the South and West Side communities of Chicago, which are the systematically disenfranchised communities, need more support. They need a little bit more support than the average person that may live in Lincoln Park. Having said that, what does that support look like? We meet the participant exactly where they are. So if they need food, if they need housing, if they need substance abuse treatment, if they need mental health, if they need someone just to talk to for a little bit, if they need healthcare, how do we make those connections? And how do we walk along with the participant through those connections as we go through the 12-month curriculum? Next slide, please. This slide, the goal of the slide is to provide an overarching view of our data and evaluation. As you've heard, our program has been evaluated over and over again through some rigorous evaluations through the University of Chicago Crime and Inclusive Economy Labs. And what you see on the slide is, what is that direct reinvestment? So the goal of Ready Chicago is to take the money that Ready Chicago has and to essentially reinvest it almost immediately into communities. So over the last 6 years, we have spent over $14.4 million directly in wages, stipends, and per diems to our participants. That's income that's going to the family. The $36 million that you see as the third bullet point, that's the reinvestment into marginalized and systematically disenfranchised communities of color through our partnership with community partners. And then lastly, what the evaluation found was our participants are 63% less likely to be arrested and have a 79% reduction in shooting and homicides arrest. That is an enormously gigantic number when we're thinking about what is the true impact at community level. And our social savings cost, because ultimately it all comes down to the dollar bill, is found to be at least $184,000 per participant. Your average return on investment is about 3 to 1. Now, I want you to sit with this as I pass you on to our next panelist, who I'm so excited to hear more about, and we'll come back and double back on what Ready does. So with that, Brad, this is for you.
Thank you so much. I'm excited to talk a little bit about the Connecticut Medicaid CHIP coverage for community violence prevention services. Go to the next slide. Connecticut was one of the first states to expand coverage, and this was done in July of 2021, and we launched the benefit about over a year ago in July of 2022. And this required an extensive stakeholder engagement. The governor of Connecticut was very much on board with this, as well as several key legislatures, both at the state and federal level, who really helped champion it through. And we worked after it was passed with community legislators and providers in this space to kind of figure out how we're going to construct this. I think we were tied with California for launching the benefit at the same time frame, and so really trying to build this from scratch. As Kyle mentioned, there's been some groundwork that his organization and others have done to really make this possible under Medicaid. And so a lot of that helped pave the way for our ability to launch in July of 2022. So just a few highlights here of coverage. I just want to point out that members have to have received treatment for an injury, which includes medical as well as behavioral health treatment for a physical and or behavioral health injury. So either one of those, and have to be referred by an enrolled licensed healthcare practitioner. And that obviously can be a barrier for potential entry into care through a BPP, but just important to highlight that Medicaid and CHIP have certain restrictions and requirements in order for them to be billable services. For providers, they have several qualifications that they have to meet, and those are outlined here. But we are enrolling organizations and not violence prevention professionals or BPPs directly, and then have to have certification through HAVI. And so that was defined by our Department of Public Health, which outlined that for us. The organizations have to have been providing services for 12 months in Connecticut, have to have association with a level 1 or 2 trauma center, and have to have a supervisor that's been working in this space for 3 years. There's more information provided here for reference, so just wanted to try to be as comprehensive for those who are interested in the details. And there's more information on our Department of Social Services website. Next slide. Wanted to also provide a brief schematic for how we talked with the stakeholders about how this would work. And so you can see here that it really starts in the top left-hand corner, an individual that's exposed to community violence. And this was defined in the statute that was passed. So it happened currently, or it could have happened in the past. That needs to then have a licensed professional assess and refer them to a violence prevention professional. Then the certified violence professional would do an assessment, a screening and needs assessment. And then those possible services provided are outlined here. So it could be conflict mediation, crisis intervention, mentorship, referrals to social, medical, behavioral health, case management, education, peer support. On the right, I outlined our payment and how we thought about doing it in a fee-for-service manner. So this is a fee-for-service unit. It's a rate that was developed by our rate setting unit in coordination and with information from with organizations that have been providing these services. Works out to $50.61 an hour, can be billed in 15-minute increments. And the upper maximum was 120 minutes a day in general, but in acute time frame in the first 30 days of service, it can go up to 240 minutes a day. And then these are the billing codes that would be used. So included those here. This is a mental health service code not otherwise specified. And then the modifier there is a modifier that allows for the upper limit to be billed in those first 30 days. So I try to keep it pretty brief, and I'll happily turn it over. And I think we're going to head on to some questions after this, and happy to answer anything about how we've done this or worked to date. So I think I'm passing over back to Estelle.
Have to always remember to take us off mute when we're off mute and off video. So thank you, everyone. This was really helpful to understand what people are doing and how we're beginning to shape the role of Medicaid and violence. And you're right, we've long known about the role of gun violence. This is not something new, but the beginning of the Affordable Care Act did change that. We now have these young men who were originally not eligible for Medicaid now in, and with that, we've seen the expenditure of Medicaid go up as related to gun violence in our hospitals. Brad, the first question is for you. We just heard from the whole range of stakeholders, all of whom approach HVIPs and other interventions at different points. There's clearly enthusiasm and expertise. But execution is everything, and coordination is critical to this work. So who needs to be at the table for the conversation around HVIPs and gun violence, and when? So
first, I'll just say I'm probably not even the best person to answer this question in this forum, but I'm happy to take a stab at it. I will say that as a Medicaid agency, we really did try to bring in a group of stakeholders that are really invested in this work, both nationally, locally, and work collaboratively in trying to design a benefit that we thought would work, acknowledging that this was one of the probably first design benefits in the country for this. And I think we tried to really acknowledge both now and at the time that this would need to be an iterative process, understanding that iteration within Medicaid and CHIP can be slower than in other sectors. And so, but back to the question, like who needs to be there? It needs to be a broad group of people that are both impacted by community violence and gun violence, and as well as those who are providing the services already in the community without existing Medicaid or CHIP funding. You need those community-based organizations and the either CHWs or VPPs that are doing this work. You need probably healthcare providers that are in hospitals that are seeing this on the front lines. And other providers in the community, behavioral health providers who are maybe seeing this, individuals for PTSD or other services. And so it's really anyone it's both people who are impacted directly, communities that are impacted, communities, organizations, a broad group, and really trying to engage them from the beginning of of this work. And I would say, obviously I'm centering this from developing this as a Medicaid policy, but it's, this is any type of engagement. You need to do it early and often and continue to do it. And I think that is sometimes a challenge, I will say, for our agency, and I'll just speak for Connecticut Medicaid, is being staffed and being able to engage thoroughly and appropriately, especially when you think about hundreds and thousands of policies that we oversee. How do we do that effectively? And we in Connecticut, the governor, commissioner care deeply about community violence, and so we've tried to engage, but just how do we do that on an ongoing manner so that people feel heard and listened to, and so our policy can reflect the need, as well as the need, and then be responsive to the ongoing challenges in terms of implementation. So I think I'll just note that this engagement, one piece back to policy, CMS has recognized recently the need for Medicaid agencies and states to do a better job of engaging more broadly with constituents. They've actually proposed several rules to enhance that, which in Connecticut, we're excited about thinking through how we can do a better job, a more thorough job of engaging with communities and providers across the spectrum on issues related to gun violence and community violence and others. So I'll pause there. Thank you for the question.
Thank you for the answer. The role of the HVIPs, as you know, and the funding of them is so critical to how we help our HVIPs both survive and to be effective. Jetty, I know your program now, since we're trying to replicate it, and Heartland Alliance has been a close friend of Philadelphia's over this past year. And as you come from a community-based organization, how important is it that these interventions involve community, and really including community members who themselves have also lived or had experience in gun violence?
Thank you for the question and for the partnership. We are so grateful to be in partnership with you. Honestly, these interventions only work if we work with and partner with communities. It cannot work as a standalone program. Heartland alone cannot do this. Ready Chicago alone is only as effective as our community partners are. So I'll take a step back and talk about our job roles, right? Our outreach workers are all individuals with lived experience who live and work, who live currently, lived in the past, work in the neighborhoods they serve. They know the individuals are right at the back of their hands. So I used to be an evaluator in a past life. And one of the things that was asked of me a lot was, how do you know when you have the right people? And the answer always was, it's a gut feeling. Now, to you and me, we're like, what does that even mean? What does a gut feeling even mean? But an outreach worker 100% of the time will know exactly who a high-risk individual is and what that partnership and what their needs are and how to meet those needs. The work that we do it creates credibility, and the credibility comes from the experiences of these individuals, from our outreach workers, from our case managers, from our crew chiefs and our coaches, who continue to selflessly put themselves in situations that are triggering for many of us and re-triggering for them. These individuals have these lived experiences. They have been part of street organizations. They have been part of the community fabric, and yet they come to work every day. And they come to work and their sole focus is to make sure that participants are being connected to the services that they need. So I cannot reiterate how important and how vital it is for communities, community partnerships, community stakeholders, the business community, all to be in collaboration and in partnership as we continue to deepen these interventions. Lastly, I'll say our goal is to connect dots for our participants. So that social support network that we're doing, that fabric that we create, we're doing it with community stakeholders, with our business community, both within that community and neighborhood and outside, as well as referral providers. So the more connections we have, the more of a safety net we create for our participants.
Thank you. Kyle, as we have seen, several states are now adopting HVIPs as a Medicaid reimbursable practice. How do you see HVIPs and other reimbursable strategies evolving over the next few years in respect to Medicaid reimbursement? Do you see them really beginning to play a key role in addressing gun reform and gun safety? I know that's basically two questions, but where do you see the HVIPs going, and what impact do you think they'll have at the end of this?
Yeah, that's a great question. Thank you, Estelle. So, I think HVIPs are going to be a very important part of what we're calling the community violence intervention ecosystem. The real goal with all of these interventions, whether or not it's hostile-based violence intervention programs or street outreach programs, or what we sometimes call targeted trauma-informed care programs, we'd probably lump Ready in there, is we want to reach the highest risk individuals, regardless of where they are. And sometimes we know people's lives are complicated. So at one point, they might be in the health system with us at a HVIP. At other times, they might be in the schools, or they may be justice involved. And the idea is that we have this full suite of services that really can meet everyone's needs wherever they are. Because finding the folks that are at the highest risk is very, very challenging. It really is. A lot of analyses have been done looking at specific cities, and if we often find that the number of individuals that are really truly kind of at the center of gun violence in the cities is very small. In fact, it's usually on the order of like 100 people or a couple of hundred people, even in very, very large cities that make the national news because of high rates of gun violence. And so if we're going to find those folks, it takes relentless engagement and all of these different approaches working together. And it gets to what you're doing in Philadelphia, right? You described it as a big team-based approach, but it's still fragile. And where we're working towards is HVIPs being one important component of it that has resources that other organizations may not, but being able to work together as a convener and take care of the patients that they have, but also be part of this larger ecosystem of programs that are trying to reach those really, really hard to reach folks. So I hope that answered your question, and if not, I'm happy to.
No, it did. I have known John for a long time and was around when Healing Hurt People was probably first a idea and a dream, and then became a reality, and then became the basis for most of our HVIPs here in the city, and they all sort of sprang out of that. At this point in time, given that they have some history, what does the research tell us about HVIPs? This is for both of you, John and Kyle. What do we need to know to support them, making sure that they are getting to scale and they are an effective model? What partnerships and supports are necessary to maximize their input? And I'll start with one little story. I work very closely right now with the HVIP at Temple, which is the largest one in Philadelphia. Over the last 3 years, they have seen the number of gunshot victims triple, and their funding has stayed the same. So what they could do 3 years ago has now been compromised significantly by not being able to do. They do something for everyone, but they can't do as much for anyone. So as you look at where we've come from to where we're going to where we need to go, what are your thoughts about partnership supports and how we make that path to the future?
Those are really important questions. I think they relate to the connection with Medicaid and future funding. One of the things that I do think happened with Healing Hurt People, we had the opportunity to move to what was fee-for-service reimbursement under Medicaid. It shifted our focus on quality and assuring that we knew exactly, obviously for the purposes of billing and reimbursement, what productivity levels were, what people were doing, how to direct and redirect our staff in positive ways to ensure that we were meeting the maximum number of clients. And so I think there's a constant reshaping of programs based on what we know. And so I know that Kyle is a far more expert in the research overall for HVIP. So I just want to offer one possible future perspective. And that is, as we have more programs, it really becomes an implementation science question, which is what works for whom under what circumstances. And so even within programs, we might say, wow, this works for half our people really well. There's another group for whom it doesn't work so well. What's the recipe? What are the difference makers? And there are methods that will allow us to do this, so that we can also in partnership decide, and we've done this in Philadelphia, is to say, there may be certain circumstances for which the Healing Hurt People model is not as effective because this is a young person who has deep street involvement. We have to be partnered, and we have to make sure that the right treatment at the right time is applied to the right person. And so as the moral questions and the ethical questions about, do we test something by providing this intervention to someone in distress over here and nothing to this person over here, has constrained our thinking given the pressure of the problem. I'm not saying that should rule out those sorts of approaches, but I think there's an array of ways that we can understand what's happening and how to go forward. Kyle, what would you say?
Thanks, John. Yeah, I would just, as a high level kind of overview, I would say that the barometer for success of HVIPs kind of depends on who you talk to. And that's been a bit of a challenge working in the field, because there are some groups that look at the violence intervention research data and say that what they want is that if an HVIP starts in a city, then that city, the gun violence will go down precipitously. That is one marker. Another angle is from I'm an emergency room doctor, so the patient in front of me is usually what's most important. And so for my barometer, taking care of that patient is, well, they have lots of needs. A lot of them they have their physical needs. I want to ensure that they have a full physical recovery. But we also know that there are tremendous case management needs and social needs. And based on the great work that they've done at Drexel, the mental health needs are astounding. So, people should not be surprised that after surviving a gunshot wound, a lot of folks had post-traumatic stress disorder. And if you think about it, in the absence of this type of program, almost none of these patients are getting treatment for post-traumatic stress disorder. And in fact, for most of these patients, this is not their first traumatic event in their life. The median adverse childhood experience score of someone that arrives at the hospital with a gunshot wound is approximately 4. So there's a tremendous burden of trauma. And so that's an outcome that we have to look at too. And so the data, when you look at this we had early randomized controlled trials. The most famous one was out of shock trauma in Baltimore. There was a randomized controlled trial in the 2000s that showed that participants in the program had a re-injury rate of roughly 4 or 5% compared to 25 or 30% in the control group. Since then, as John mentioned, there's been a move away from randomized controlled trials, largely due to ethical reasons. And most of these retrospective studies have shown re-injury rates of 4 to 5%, and that when you look at patient-centered outcomes, addressing mental health needs is often what the patients themselves say are their biggest needs and get met at very, very high levels. Now, I'm not saying that the research is perfect because we need a lot more of it. We've been constrained over the years. The Dickey Amendment really minimized this for decades. But when you look at across the span of outcomes, the evidence shows that these programs are likely effective, but we do need more research.
Thank you. Moving back to you, Brad. Connecticut was one of the early ones. I think, as you said, you were probably either 1 or 2, depending on where California was. But I actually think you were number 1. Made HVIPs Medicaid reimbursable in 2021. Since you've implemented the benefit, how in your judgment has it worked? Has it basically accomplished what you and the administration wanted it to do? What are some of the challenges that remain, and how do you see either changing it or adopting it as you move to the future?
Yeah, I think great question, and definitely. I was just looking back, and I think Governor Malott here in Connecticut, I think we may have signed the bill first, just ahead of, I think, Illinois. I'm sure Kyle can correct me here. And I think our implementation may have been at the same time, July 1 of California. Kyle sees nodding, so that's good. But just to say that I think how has it worked, which is a great question, and I think something that is sometimes even challenging for us to assess. And what I can say is we implement the policy again in coverage in July of 2022. So we're a year and a few months into it. We have 1 enrolled provider, but we actually have 0 claims as of now. So no one's actually billed. And so I think that is one, I think, disheartening to see that it hasn't been used. And so I would say, is that an overwhelming success? Obviously not. And I think it's an opportunity for us to reflect upon how we've constructed the policy, what's going on. And we have engaged in conversations. I think one of the successes that we've had early and continued engagement with some of the folks who are operating violence prevention services in the community to hear about, okay, well, why wouldn't you enroll as a provider? What are the challenges with billing? And I think for anyone that's worked worked in healthcare and has billed insurance or Medicare or Medicaid services, there are frictional costs to being a provider. There are challenges with enrolling, and there's challenges with billing, and there's rules, and those are things that are not usually waived. There's reasons they're in place, and so I think we are very interested in looking at how do we reshape it. Again, I think having built this as one of the first programs in the country or coverages, we didn't know exactly what would be successful. I think one of the things, Kyle, you mentioned and came up is how do we measure our policy success? And then how do we know, even if people are using it, that it's working effectively? And I think there's a lot of opportunity for evaluation of coverage policies to say what does work the best for a payment, not only which operational program is the most effective for which population, but which payment model is the most effective for which organizations. And these are complicated questions. And I actually think there's a lot of opportunity for continued research and evaluation. So I'd say we're still in the infancy of this. We acknowledged from the beginning this would need to be an iterative policy change. And one of the biggest challenges of getting this into practice, I think, is that when you put a policy in place, especially a governmental policy, changing those policies, we're not always as fast to change as in other sectors. And so we are more slow to change for various reasons, and that just means that we have a gun violence crisis in our country, and meeting those needs is not always as easy as we'd like it to be, given the policy constraints that we're under. So I'll pause there, Estelle, but I think it's a great question. Thank you for asking.
Thank you. And it's good to hear that update, and that I think all of us who've been in and touched the Medicaid world know that it stays a challenge. And as soon as you solve one, there's another one that popped up. J. Eddie, one of the things, my background is very much in behavioral health. And one of the words that has come up several times is the role of behavioral health in gun violence and how we work on it. I am absolutely work with a lot of people around cognitive behavioral health. I know you described it as slightly different than the more professional, but it also, from much of the data I've seen, particularly the data coming out of Chicago, it's a more effective model. Can you talk a little bit about how CBT and the risk of gun violence all work together, and why do you believe it's been so effective at your train the trainer model?
Thank you for that question. I agree with you. What we found with community violence intervention, which has been around for decades, if you think about street outreach work, it's been around for a minute. What Reddy found in 2016 was responding just to the supports and responding just to the referrals isn't enough. We need to make a fundamental shift in the way people think and how they're actually processing the information. So that's where the idea of the cognitive behavioral intervention model came up. We wanted to be able to allow for people to take stock of where we're at, identify your triggers. What do they actually look like? Once you identify those triggers, taking a moment to see what are the best coping skills. So what may work for you, for example, may not work for me. One of the things that come up a lot as I've been in this field has been exercise, right? Everyone tells me if you work out, it helps with your stress hormones. And I'm like, great. If I'm stressed, I'm not going to a gym. That's my coping skill, right? And so for me, I know what I need. I need to sit down and read a book instead. I can't go to the gym. That'll stress me out even more. And so what we found was our participants are facing similar problems where we're trying to say, oh, you should do this laundry list of things when you are triggered. But when I'm triggered, I'm not taking stock of that laundry list. I need to know what my here and now is. And the unique thing about the Ready Chicago model is that it not only infuses the teachings and the education piece, but it also practices that piece with you. So that transitional jobs piece, that subsidized employment piece is where we create an environment where our participants are being exposed to work stress. You go to work, someone says something and you snap out. How do you not snap out and take that 8 seconds to reevaluate what is the most effective way to respond to a potential trigger? And how can we do this in a way that doesn't hurt the individual, but also doesn't hurt the person that is seeming like this is the one that's accusing them of something, right? And so that's how the Ready Chicago model and the CBI interventions came to fruition. As it relates to Medicaid, specifically, I do want to address, so we use the IMCANS as a needs assessment, the long 22-page document that assesses our needs. That document is used to be able to help identify truly where our participants. So how can we continue and further leverage state assets to promote case management, to promote the connection of resources and referrals, and to create this network of support for high-risk individuals in our communities?
This just sounds great, and I'm glad that we are partnering with you so we can learn even more. Kyle, I think a little different from Connecticut. Many states like Pennsylvania are Medicaid managed care states. So we would be operating a Medicaid waiver through a managed care entity. What will that mean as we look at engaging managed care plans? What are the things we may need to be aware of, or things that we need to be considering if we're writing a waiver that will then work through, not directly back to our hospitals or providers, but through the plans?
Yeah, great question. And that's an issue that we are actively working through right now nationally. The addition of managed care, it changes the dynamics, right? Without managed care and fee for service, you've got the program, you enroll as a Medicaid provider, send a bill to the state, and that's that. Brad, you can say why that's much more complicated than that when you'd like to. But in comparison to managed care, the state sets up, high level guidelines on, what a, sample level of care is and the sample rate. But in reality, the programs and providers are going to the MCOs and directly negotiating. And what we're finding is that does add quite a bit of complexity and extra work and education for both the programs themselves as well as the plans. So we're working through this in California right now. California created the benefit under its community health worker benefit, actually. And I saw lots of questions in the chat about that. So in California, actually, the violence prevention professionals are designated as a form of community health worker for purposes of Medicaid. So what we're finding, though, is that billing Medicaid for the programs, this is a brand new endeavor, which that's the same as everywhere in the country. But also for the plans, this is a brand new endeavor for them as well. And so before programs can even start negotiating with the plans about rates and payment models and structures, we're having to do a lot of education with the plans about what is a violence prevention program, because what we're finding is a lot of the people on the plans, they're projecting what their own ideas are of it. And a lot of times they're thinking domestic violence or intimate partner violence, or they're thinking safe storage of firearms. And they really need a lot of education and handholding to learn what community violence intervention is. And that there isn't just one model, right? Healing Herd People has a different program model than Ready Chicago. And they're both doing fantastic work that is patient-centered and saving lives and improving lives. But what works for payment for HHP is probably not the same as Ready Chicago. And so it is a lot more work and education. On the flip side, we're hopeful that once we start getting some of these sample contracts with plans and programs, that it'll be great models for other communities for ways that this can be rolled out. So that ability to tailor and that a little bit more of the negotiation does have upside too.
That's great, and it's good to remember that, and I think someone said it earlier, that there are going to be a variety of ways up solving our problems on gun violence, and it's going to be very adaptable to the cities, to the neighborhoods, and to the tools that we have available. Thank you. I'm going to stop the questions because I see we have so many in the chat at this point that I want to turn it over to Allison so all of us can get to some of the question and answers from our audience today. Allison?
Thank you so much, Estelle, and what a great discussion. I'm going to field the first question to John, and that is there's a lot of excitement across our audience today, and there are some questions that sort of get to the issue of how do I get started if I'm operating one of these programs in a community? How do I connect to the right stakeholders around me if I don't know if one of these programs is operating in my community? Sort of, if I'm interested in this issue and interested in making these connection points, what advice do you have for folks in terms of where to begin?
Sure, it's a great question, and I think we are currently in a circumstance because of the Health Alliance for Violence Intervention, where we have truly a clearinghouse, and I would use a word I don't even use that much, which is brain trust, of the most brilliant minds who are working to bring together, create a community of learning, create a community of practice. There are a tremendous number of resources that, to be honest, when we started Healing Her People, we were hungry for. And so there's also an opportunity by involvement there to actually go and see other programs, to identify programs that are doing something like what you want to do, because there are different, to Kyle's point, there are different approaches. For example, when we started out, we went to visit Oakland, caught in the crossfire. That was a community-based organization that was partnering with a hospital, we were attempting to start something in a major trauma center. So there were some differences. But even now, there may be institutions that are not level 1 trauma centers that may be seeing people not with the most acute injuries, but maybe seeing people in the aftermath. So there are different considerations, different staffing needs, different capacities that mean that this is what makes it tough, right? It is a program that's going to be customized to and with the community that is being served. And so I would say a great place to start, even just to start, is the website for the hobby, to connect and see, particularly to have the opportunity to come to the annual meeting. It's annual, right, Kyle? The annual gathering of the hobby, which will be a rich resource of many, many folks doing this work in very different ways.
And John, if I may, I just want to yes and all of that, and let folks know that we're in the process of creating what we're going to call our Medicaid Resource Center, that is compiling all of the states that have done work, and we're going to have all of the nerdy details on there with links to state plan amendments and payment rates and all of that. So we're looking to launch that before the end of the year. It's not up yet, but we're building it out in process. So just our website we're trying to put as much information for the field on there as possible. So please take a look.
Let me jump in too real quickly on one of John's statements. What Philadelphia did was visit these programs. We visited Chicago, we visited Oakland, we visited Indianapolis. So part of it is getting out and seeing what the other programs are doing and seeing where they overlap with where you want to go, and taking possibly the best of all programs. But everybody is young enough and new enough now, and it's so exciting going on. Being able to get out and visit programs is a good way to shape your own.
Thank you so much for that. And Kyle, I think you saw the virtual applause for the Resource Center. There's a lot of questions that I now don't have to field to you about where can I find information comparing how different states are structuring this benefit and service and so forth. And so the answer there is it's coming, folks. Stay tuned, and we'll make sure to include in resources that we send around the link to the Hobby website. And Kyle, I promise we can keep in touch and share and help you disseminate information about the Resource Center when that is up and running as well. I want to turn to you, Brad, and I'm going to open this up to others on the panel as well. So, Brad, I think you sort of gave us a dose of reality when we're all excited that Connecticut is among the first out of the gates to offer this as a Medicaid reimbursable service. But the dose of reality is just because you put it in the benefit package doesn't mean that there's take up, right? And there can be a chasm between hope and reality, right? In terms of getting to the, realizing the vision of offering a scalable, sustainable funding pathway for these programs. And so the question that comes to mind, and I saw this come through our audience, is about technical assistance. And I'm curious if you all have been thinking in Connecticut, and again, I would open it up to others on the panel for thoughts on the type of technical assistance. Jayati at Ready Chicago, what technical assistance have you received or do you wish you had in order to sort of achieve that vision of fully maximizing Medicaid funds for scaling these services? Because we've seen this in other areas. This is not unique to HVIPs. Just because we launch a new service in Medicaid doesn't mean that community-based providers have the capacity to avail themselves and to implement the billing processes and systems and structures to take advantage of that. And so welcome thoughts in terms of how you might be thinking about approaching this in Connecticut, and again, from others on the panel, what technical assistance you think would be most helpful to community-based providers to sort of maximize the opportunity here?
Great question. Happy to kick off and just say, it definitely came up as part of the process. As we were thinking about launching, it's like, okay, well, if someone's an active provider in this space, how do they become enrolled? Realistically, we have a limited group of folks at the agency that are able to help with onboarding providers. And a lot of those resources are for providers that actually are used to billing or healthcare providers. And so I think this applies, as you said, Allison, not just to violence prevention professionals, CHWs, potentially doulas, other community-based organizations that may not be used to being providers in this space. And I think there are creative solutions. I don't think we in Connecticut have come up with the answer. I think I'd look to other states that have thought about bringing on help to provide technical assistance to these types of maybe newer providers in this space. And also opportunities to engage, to think about how do we reduce frictional costs to enrollment into being it. Obviously, there are very specific requirements to become a Medicaid provider. These are often not things that can easily be waived, but there may be things that we can do to make it easier to meet those requirements or to understand it. And I think that that is something that needs to be thought about, as well as funding for those initiatives, because it's not insignificant. And I think we're not necessarily at this time resourced to do that as effectively as I think it probably is needed to get more providers on board. So I think there's a lot of opportunity in that space moving forward, especially as we think about non-traditional healthcare providers helping to improve community health and well-being.
I think I'm going to second everything Brad just said. We definitely need the education. I think there's the lack of education in the space of how do we connect the dots, because traditionally we never have. And so how do we connect the dots, but also what are the barriers and how can we creatively, I'm just going to steal your words, Brad, how can we creatively come up with a solution so that we can all try and apply and leverage the state assets that we have? I think for Ready Chicago, something that's worked a lot for us is, to Estelle's point, go out, hear more, see more. What does it look like on the ground? And how do we connect those dots from, maybe learn from Connecticut and move it back to Illinois? What are the barriers that Illinois faces that Connecticut may not face? But create partnerships, thought partnerships, brain trusts, to steal your word, John, something like that, so that we can create a collaboration of people that can actually help continue the learning that other states have.
I'll just add one quick thing, just a second, and just a big thanks to Javi, Kyle, and the broader team. Just have been excellent collaborators for us as a state to learn about how other places are doing it, making connections so we talk to Healing Hurt People. We've had numerous conversations along the way in terms of designing and building what's been done in Connecticut. And having partnerships like the one with the Javi has been instrumental for us. And I think just a large shout out to the broader team there and Kyle's team for really helping and continue to be great resources along the way, because I think we're all in this and for the same reason. Obviously there's decisions on policy, payment, all these things where there may be differences, but obviously we want to provide services and really help in this crisis that's ongoing. And I think learning together is something that Javi is being an amazing example of how to do that.
Thank you, John. Thank you, Brad. I just wanted to, make sure I shout out our partners in the training technical assistance arenas. The Javi, we are known for hospital-based violence intervention programs, and we do quite a bit of training technical assistance for that. But we're also part of a bigger group called the Coalition to Advance Public Safety, which is us, the Community-Based Public Safety Collaborative, National Institute for Criminal Justice Reform, and Cities United. And so especially when we're looking at communities, in many communities, we're working together because, like we've said before, these different forms of violence prevention, they have different needs. So the Community-Based Public Safety Collective, they're the experts in street outreach. So they do the training there. We do the hospital training. Cities United helps organize city responses. So please check that out and see if anything is a good match for what your needs are. There's also lots of great people locally too. So I don't want to forget about that. So for example, in California, the Urban Peace Institute does incredible work. And there may be folks in your own state that are doing training and technical assistance. So please check out your local partners as well.
Thank you so much for that. And we will send around some follow-up resources to all folks registered for this event. And so we will try and aggregate some of this really helpful information for you today. Kyle, we got another question. So a really timely topic in Medicaid right now is the new opportunity for states to cover an array of services pre-release from jails and prisons. And we've seen a number of states receive approval from CMS to offer this coverage, whereas historically Medicaid has not been able to pay for services in these settings. And so our audience is curious for a linkage, to the extent there is any, between that activity and Medicaid reimbursement for violence prevention services. Are you aware if any of the states who are pursuing those pre-release coverage waivers are including violence prevention services in their request to CMS?
It's certainly an area of interest in ours. And, you know, in some of the states, I saw that in the Q&A, they mentioned a number of states. I'm most familiar with California, where they've included reentry service as part of their CalAIM waiver. That's something that programs on the ground have looked into. And I think it's important to know that this is probably a good opportunity for the area, but it isn't 100% match, and it's not going to cover 100% of what programs are doing for violence prevention. It's worth noting, you know, if you think of the Venn diagram between folks that have been injured in gun violence, folks that have perpetrated gun violence, there is some overlap. We all know that. We would be lying if we said there wasn't, but it's certainly not 100% overlap. So there may be a subset of patients that would be well served there. And I do think it would be very, very smart for programs that are doing violence intervention programs to look into that and probably look into interesting collaborations, particularly with folks that are doing substance abuse youth work, because we know that that intersection is pretty high as well. And that population has unique needs compared to people that are in the community. So it's an opportunity. It's kind of at the forefront that people haven't jumped into quite yet, but it is there and people are starting to look into it.
I'll just, if it's okay to jump in, I'll just say as a state that's applying, soon will be applying for justice involved waiver. It's definitely come up as part of the conversation, acknowledging that we already are starting, we have some coverage of violence prevention professional services, and how do we think about pulling these things together? I don't think we'll probably will do more work to think through that. And you could imagine our current, even what we're currently covering would actually apply and actually provide a fee-for-service payment for individuals who are working with those post-release. I will say it's another opportunity to think about innovative finance models for states, especially to think about, you know, I think this came up earlier with violence, with the expense, I think Estella, you mentioned, the expense that goes into caring for individuals who are in the hospital who have been exposed to violence or victims of violence, very high. Are there opportunities to use some of that savings to fund providers? And the same for folks who are being released to go home from incarceration. Those reincarceration rates are quite high. Are there opportunities to share with community-based organizations the savings that the state sees and to provide funds in that mechanism? So I think creative financing solutions are possible. There's a lot of barriers to doing it. There's reasons that states like Connecticut are not usually doing this, but I just want to throw that out there as a possible future solution where there are dollars that we're spending in thinking about how do we redistribute those.
Thank you.
Can I just say one other?
Yeah, quickly,
John.
John. Thank you. Yeah.
So one of the things that's possible, and we had some, I won't go into the details, but some restructuring of the hospitals in Philadelphia. And what we were able to do was to partner with community-based organizations or other city organizations that were serving the needs of young people who had been in the juvenile justice system. And they were able to identify within their population some folks who had trauma-related issues, and we were able to partner and serve those folks. And I think it's really important because the staff who do this work are doing hard work all day. And sometimes the work can be overwhelming and traumatizing to them. So identifying in there a mix of opportunities for seeing people at the bedside after devastating injuries, while also being in places where there's a greater opportunity to know that you're focused on helping with the symptoms of trauma, but there is a a surrounding support for that individual. So there are lots of opportunities to make sure that we're sharing, even if one of those organizations has Medicaid reimbursement and the other doesn't.
Thank you for that, John. Well, we have quickly exhausted our time here today. I'm overwhelmed by the amount of expertise and just activity represented among this panel, and filled with optimism for how Medicaid can more actively partner. The best thing about Medicaid is it just takes one or two states to figure out how to do it, and then it's relatively straightforward for other states to follow in their path. And certainly we have every interest in supporting that peer-to-peer learning across states, and look forward to talking more with our panelists and with many of you in the audience about opportunities to do that. Thank you so much to Estelle for moderating today's session, to all of our panelists for their contributions, to all of you in the audience for staying with us for 90 minutes today. And we promise to follow up with additional resources to support you in your efforts in this area. Please be in touch. We'd love to hear from you. Our website is up on the screen. I'll remind you that there will be an evaluation popping up if you have a moment to fill that out and let us know what you would like to hear more about. So thank you to everyone once again, and I wish you all a great rest of your day.